So good evening everyone. So continuing with the theme of mentorship, we are going to talk more about something more specific, subspecialty training. May that be subspecialty training in India or abroad. And the next two sessions are going to be about subspecialty training. We have divided it into two parts. The first is subspecialty training, what the mentee seeks. So it's from the residents or a fellow's point of view. And the second session is from the mentor's point of view. So for the first session, as chairpersons, I kindly invite Dr. Gautam Chakravarti sir and Dr. Rujuta Mehta madam. And we're going to keep it as a panel discussion. And I want everybody in the crowd to be inclusive, to put up their hands and ask questions if they have. You can stop us at any time. If you want any clarifications, please go ahead and fire away. The panelists for this session are Dr. Manit Gundavda, Dr. Prashant Meshram, Dr. Vikas Gupte, and Dr. Chasnal Rathod, madam. May I just request the panelists to please take the chairs. Yeah, Prashant, Manit, Dr. Gupte, sir. So in this session, we are going to focus on how to decide a subspecialty, how to choose an appropriate fellowship, and how to apply for that fellowship in a way which maximizes your chances of getting it.
So, hello everyone, I'm Dr. Nandan Marathe and I'm the co-convener for this session along with Dr. Nikhil. So for today's panel discussion, we have experts who have traveled the world and we have tried to cover all the subspecialties. So to introduce them briefly, we have Gupte sir, who is a consultant, specializes in minimally invasive spine surgery. He has done his fellowships from Korea and Japan. We have Dr. Chasnal ma'am, who is a pediatric orthopedic surgeon. She has been to Korea, USA and Canada. Dr. Manit Gundavda is an orthopedic oncologist. He has traveled to UK and Canada. And Dr. Prashant Meshram is a shoulder and knee surgeon with experience in US and Korea. So without wasting any time, we'll directly dive into the questions and let's start off with the first question. So I want to ask all the panelists that when and how did you decide which subspecialty to pursue? Was it during residency? Was it during post-residency, during maybe your bond period?
Shall we start with Manit? Yeah.
So I was lucky to train with Dr. Agarwal, who does only orthopedic oncology, and I was exposed to this specialty very early in my residency. And as my boss calls it, it was a fatal attraction. I just knew it was so fascinating. I knew I had to pursue it as a specialty for myself as well.
Okay. Prashant?
So this is how I usually put it. It's like choosing a subspecialty or a job which you do every day is like choosing your life partner. Okay. You spend at least 8 to 10 hours of your day doing that. If you don't like it, you're going to hate your life. And so it's very important that you choose something which you love, you have passion for, something which keeps you awake in the night, something which makes you look forward to go to the OR in the next day. So okay. For me, that was the time when I started, I had my initial experience. KEM gave you a perfect platform of having experience in spine, knee, arthroplasty, scopes. So make sure that before choosing the specialty, get experience in each and every field, at least for 3 to 6 months, just to see what connects with you. And once you do that, find a good mentor and do at least a 1 year of fellowship or follow them. And that is when you connect, you choose that, and then you go ahead with it. But don't choose it unless you love it and it keeps you awake and keeps you going to the work like enjoyable and joyful.
So if I may just interject, madam, before I come to you. So right here we have two different views. So Manit, you chose your subspecialty because that is what you were exposed to and you got inspired with during your residency. Whereas Prashant, you feel that it is important to have a biopsy of all specialties before finally diving into something more specific and something you like to do. Is that correct?
That's correct.
Okay.
So like Prashant said, I did go through every specialization, but I was exposed to it. This is not a specialization that is routinely most residencies don't have exposure to the oncology rotation.
Yes.
And like I have done my rotations in each specialization, but this was just out of the books, and I knew I wanted to do it.
Okay, thank you. Madam, if you could just tell us.
Yeah, so first of all, for me, taking up ortho itself was challenging. So when I was in my internship, that's when I decided I want to take up ortho. Because I used to go to all the all the departments, and they never seemed fascinating. The ortho OPD was like, they would put up a pre-op x-ray, and then there's a next x-ray with a nail, and everything looked perfect. So then I decided to take up ortho, and that point itself, I had decided to do pediatric ortho. And I think I had visited one of the meetings where Johari sir was talking like for an entire day. And that's the point I decided I'll do pediatric ortho ahead. So that's how I came into this field.
So you feel that it is important to be inspired during your journey?
Yeah, I think
And you
internship is the best time
Yes,
because then we get exposed in a year through all the departments.
Yes.
And probably you can pick up what you're good at. If you are
Yes.
good to see the ECG and murmurs, yes, take up the MD.
Yeah.
But the surgical field, that's the point where you decide.
You're lucky enough to have a good internship. Everybody these days is,
And the best part,
doing
I'll tell you,
MCQs.
in internship, they allowed me to put a skeletal traction, and I was like, oh my God, I'm taking up ortho. So I got to put a calcaneal pin, and that was the turning point. Probably I would have taken radiology, what
Fantastic.
my parents wanted me to, but the ortho was the skeletal traction.
Something which inspired you, and later to subspecialize as well. You said you saw Dr. Johari and you got inspired.
So I'm from an era where there wasn't subspecialization. There was generalized orthopedics. And I trained in India, in JJ. But when I came out, there wasn't hip surgery and knee surgery, and hip arthroplasty and knee arthroplasty was still primitive. And I went through the training process again in the UK. And as I mentioned before, I was educated in India, but I really was trained in the UK. And that's when I, having been through every specialty, and that is what UK training exposes, I realized that knee surgery is the area that I want to really progress with. And you need to be able to get up and go back the next day and say, yeah, that's it. Knee surgery is what I want to do. Knee surgery is what I want to earn my bread and butter. And that's how I became a knee surgeon. And I have practiced knee surgery for the last 26 years.
If I may interject, sir, I mean, even general orthopedics is extremely exciting. But
Of
do you
course.
feel that in today's day and age, subspecialty has become necessary to
Yes,
say, be relevant?
because you can be the jack, but you can't be the master of everything. And orthopedics has improved and galloped away quite significantly because of the technical and digital advances. And it's impossible for you to be good at shoulder surgery, spinal surgery, knee surgery, hip surgery, and therefore the need to subspecialization has improved. I cannot deny that market forces don't drive that as well. And there is a lot of influence from markets today, from commercial organizations and within your own setup to actually, for you to move that forward. But really, as a doctor, and I'll be very kind of old in saying that your Hippocrates oath, don't get driven by that. Do what you think is best for your patient and do what your ability serves you. And that is what is important before you jump into practice. Don't let the market forces dictate what you want to subspecialize in.
Yeah.
Let your own skills dictate what you want to do it. If you want to be an arthroscopic surgeon and you do not have 3D skills, let's forget about it.
Yes.
Do something different.
So as you rightly mentioned about market forces, there's always an element of that which is going to be a part on when you decide your subspecialty. For example, there are emerging subspecialties like, say, in India at least, like foot and ankle surgery or hand surgery. So while training, the residents don't really have that much of an overview as to how market forces are later going to dictate their practice. So maybe exposing them, to that side of practice can influence their choice as to what subspecialty they can choose.
Absolutely.
Because not everyone might be inspired by, some mentor to take pediatric orthopedics or orthopedic oncology. For some people, it is just a job. It's just,
And that is where the Indian training falls short, because in 3 years, it is impossible for you to go through every region. Even if you count hip, hand and wrist, spines, hips, knees, foot and ankle. It cannot be done in 3 years. And you need to spend at least 6 months in every subspecialty to actually understand the basis, and then come back and visit that subspecialty again if that is what you want to, that's what you want to do, which is exactly what happens in the UK.
Dr. Gupte sir, you had a different experience from most of them. You were in private practice for quite some time. Then you subspecialized in spine, and then you started your specialty spine practice.
Yeah.
So can you tell us how you made the decision
yeah.
and how your fellowship training, subspecialty training has made a difference to your practice?
Give me some time.
Yes.
I am the odd man out. I passed my MS from Nair Hospital in 1987, and I started my practice in 1989. I was compelled to start. I wanted to learn something more, but I was compelled. Family circumstances compelled me to start earning. So I started my practice in Mulund area. Next station is Thane, and our teacher, Dr. Ingarikar, was there. So I was practicing general orthopedics, but there was quite a lot of patients of backache used to come to me. And as you know, in practice, people go everywhere. So I used to see patients treated by Dr. Ingarikar, and I was really impressed with his approach to the patients, his treatment. He was my role model.
Right.
So from that time onwards, I developed interest in spine surgery. There's one particular incident in 2003. I was to operate one old man with medical morbidities, his lumbar decompression. We took him up in in operation theatre. Mind you, I was operating in a small nursing setup. Our anesthetist started inducing him, and he suddenly developed severe chest problems, and we had to abandon the surgery. His condition was such that he has to undergo surgery, otherwise he would have been paraplegic. Somebody suggested him to go to Pune and see Dr. Gore. Gore is an endoscopic spine surgeon who had come back, just started his practice that time. So with my permission, patient took a discharge and went to Dr. Gore. And mind you, 2 days back, that same patient who had traveled to Pune in an ambulance came to me walking. He was operated by Dr. Gore under local anesthesia using a transforaminal endoscope. I was really impressed. I was really zapped. I said, this is something I must learn. Incidentally, around same time, IOCON Ahmedabad happened. And there was a workshop on in spinal endoscopy. Dr. Anthony Young had come. So I attended that workshop. That time I met Dr. Gore. I interacted with him. Dr. Gore said, if you want to learn, you come and see my surgeries. So for next 1.5 years, I used to travel. Whenever Gore's surgery was there, I used to travel to Pune from Mumbai, attend his surgeries in the morning, come back around 2 o'clock in the afternoon, and start my practice. I did this for almost 1.5 years. Then there was IOCON in Chennai. That time, Dr. Gore arranged a spinal endoscopy workshop there. And Dr. Gun Choi from South Korea had come there for demonstration surgeries. And myself and Dr. Pradyumna Pai, we washed up with him in operation theatre, assisted him for one surgery. Second surgery, he said, you give a root block and show this thing. So that was in 2003, December, I think. So he said, you people are quite interested. If you want, you can apply for fellowship in our hospital. So we both applied for fellowship in Buridul Spine Hospital, South Korea, and got selected. I worked in Buridul Spine Hospital for 1 year, stopping my practice. Mind you, it was 15 years private practice. I am a owner of one small nursing home. When I stopped my practice completely, and I had to, I taken loans. My eldest daughter was in 12th standard, and my wife, of course, my wife is a gynecologist, but you have to manage all the finances also. That time, my outgoing was 2 lakh rupees per month. You have to make a provision for that for 1 year. After doing all that, I stopped my practice completely. 2004 March, I went on fellowship
for specializing in.
Yeah.
So I think the take-home message is that it is important to be inspired by a particular branch or a particular person and try to find something which you actually like, and that can be at any stage in your career. It could be during internship, it could be during residency, it could be in the immediate residency period, or it could be 10 or 15 years down the line when you realize that you like one particular thing and would like to pursue it. So moving on to the next question.
So, we've learned that how everybody found their calling, but the next step is how do you get into a good program? That's where a good CV comes into the picture. So, I want to ask all the panelists that how do you strengthen your CV to improve your chances of getting into a program? Everybody wouldn't get an opportunity like Gupte sir had, wherein he directly, got a chance to demonstrate in front of the mentor himself. So the usual way that we get in is submit your CV to a program and get in. What is the relevance of publications? What is the importance of networking and recommendation letters? So we'll start off with Dr. Manit.
So just to remind everyone, Manit has done his fellowship from Toronto in Canada, and you were in Hinduja for a while.
Yeah. So I think basically strengthening your CV goes back to the interest in your subject and your subspecialty. The more you're interested, the more you'll read, the more you'll look for questions that are not answered. You will talk to your mentor and find out whether the questions that are not answered are worth pursuing, and is it possible to look at that. And I think that was the basis of most of my research. Most of my research answers questions that have not been answered already in literature, and that makes a useful presentation, useful publication for the readers as well as for you to read and learn more about the subject that
So
way.
it's not just about publishing for the sake of it, but publishing something useful.
I have read most of my subject through writing papers from questions which have not been answered.
And importance of networking, your boss putting in a good word, do you think that makes a difference?
So again, it comes back to research. If you're doing good research, people come up. I mean, my trip to the UK was when Lee Jays from UK came up to me and said, I'm interested in this study you're doing and come over and do a stint with us. So that's how it happened.
So research is a good starting point.
Dr. Prashant, your comments.
Just two things. If you want to make your CV strong, what the mentors look at when they're selecting candidates. I was in Korea. I was a part of the selection process, and that's how I got into the insights of what they look for. They look for basically three things. The first one is definitely if you have good recommendations. That is the key. When I went for my fellowship at Hopkins, it was a research fellowship. At that point, when I was submitting for it, I did not have a single publication. So no publication. I get into a research fellowship in Hopkins. It happened only because I spent 1.5 odd years doing research. I was doing research. It just takes time to publish. But my boss was like, there's an opportunity there, and he gave a very strong word of mouth. That got me in. So that's a key message. Number one is networking. You need to have your local mentors who push you to have overseas mentors, right? I was one of the assistant professors here recommended me to Korea. From Korea, the stepping stone was to go to the US. It was a fully funded research fellowship. I could never imagine being a resident here and going there. So number one is your recommendation for the CV. Who is recommending you and what stage they are going in recommending. Are they just giving a copy-paste letter of recommendation, or they are editing it themselves? And I have been lucky enough that my mentors have gone beyond step to write the CVs themselves and also emailing the fellowship coordinators themselves.
Yes.
So it's just not the number of recommendations, but the quality of you have one strong recommendation and you're done.
Whether they've picked
That's
up
number
a
one.
phone call or not. Yeah.
That's number one, is your letter of recommendation, and it has to be strong. References, networking. The second thing they look for is your publication. Because in India and in most of the parts of the world, for the mentees or for the students, there is no real motivation to publish because there's just so much clinical work. So there's someone who went beyond their, made time for the research and was productive, diligent, and that gives them a chance that, okay, so this guy is, willing to go beyond the comfort zone and publish things. So there are two things which are very important if I'm checking someone's CV. Number one is who is recommending and to what quality of recommendation that is. Yes. And the second thing is, if this guy has been productive in research, that's the two things are most important.
To keep proving your usefulness at every point to your colleagues and especially to the people who have the potential to refer you to a better program. Yes, madam. What in your experience is it?
So during my time it was slightly different, but what I would suggest currently people to do is that now people from Southeast Asian countries, suppose we consider Korea, Japan, they always want to see if we have had a basic exposure of the subspeciality back in our country. And of course, India and Mumbai is like the best place for healthcare. Of course, we know people from all over the country travel to Mumbai for their treatment. And once they know that we are from a good city who has worked in that specialty for a long time. So I was in pediatric ortho at Wadia for 2 years before going for my first fellowship to Korea. And that's how I got a 1-year clinical fellowship. I was allowed to operate there. I was supposed to take the teaching programs for the R1, R2 and R3. So that makes a difference. Rather than just going for an observership or a short fellowship, you have a strong base back in our own country, have a good local mentor who's going to recommend you, and that is going to build your CV. The publication doesn't matter much because they all know we are just starting our career. All they want to know is, do you have a good experience and are you sure about what fellowship you're traveling there? Like they have fellows there who come for spine fellowship, then 3 months later they are doing joint fellowships. So they're hopping in the same hospital for 2 months and they don't like that. Actually, they don't like that. They prefer people who have worked for a longer and for a consistent period back in their own country. And of course, India is on a higher level because they think we are very fluent at English. We are very capable of writing papers there, and they are very open to have us rather than people from Egypt, Turkey, or other countries. So that's how we are at a higher advantage already. So getting a good base back here and a good mentor, good recommendations always works in the long run. Do not worry much about publication here. Of course, now we have good EMRs and we can get data, but earlier we had tough time in Wadia. Like 15 years back, we didn't have any data to publish. It was tough. Ki 1 year mein ek paper nikalna was very difficult.
Very important point that you brought about was commitment to your subspecialty. In the second session, we have Nene sir who will be talking about spine, and I was briefly discussing the session with him, and he said, I have only 2 basic requirements for a fellow. One is he should be willing to do a structured fellowship amounting to at least 2 years, and the second commitment that he wants from his fellow is he should practice as a pure spine surgeon and not do orthopedics. So commitment to your subspecialty is important. Gautam sir, your thoughts?
So I'm going to go back a step for the juniors here. What is the meaning of a CV? We always look at a CV as a piece of paper, but CV is your face that I cannot see, but I can imagine. Your CV should reflect yourself, and in that should be your USP. Because if there is no USP in your CV, I'm not going to be impressed. For 25 years, I've been doing that. I get 60 to 70 applications. I've got 1 post. How am I going to make that decision that which of the 60 or 70 people are good? Because everybody's got an MS Orth, everybody's got some medal somewhere, everybody's got a prize in school, everybody is good. But who is the best? How do I make that decision? Just imagine you're going to a display of a shop window. However good the contents are inside, if the display is poor, you are not going to go into that shop, are you? The display is what will attract you to get inside that shop. Your CV will allow me to explore further. If you have publications and if I'm keen, I will look you up. If I see your names of your referees who are known people, they don't need to phone me. I will have some sort of inkling, this guy comes from a good institute. If you write there, I've done 1 year of pediatric orthopedics, you're applying for a pediatric fellowship, I get interested. But if on the other hand, you're applying for a knee fellowship, but you haven't done a knee job, I'm not interested. Does that make sense? And that is what needs to come out. Do we need publications? Yes and no. Publications allows you to develop your critical analysis of the subject. By reading up journals, you develop that, and then you automatically develop an interest to probe your own practice and actually write something about it. And that becomes very important. In the UK, we do not get references till the interview actually happens, and that's the law. That's the employment law. So unlike here, like the US, where you send a letter of recommendation first, we are not allowed to see it because the human resources will not allow that to happen. Yes, a telephone call helps, but it's not a one-man decision. The panel has to be impressed. Or if the same person rings all of them, it is not a good thing. However, your CV will actually sell you. You need to be able to sell yourself, and the CV is all about your presentation. We often see a lot of Indian CVs with the basic grammatical mistakes. That's a very poor reflection. Somebody who cannot spend time to use a spell check on Windows Word to correct the spellings doesn't impress me. Because you don't even have to know the spellings. It comes up. You have to just sit and correct it. And if you couldn't be bothered to do that, it does tell me that you're not going to be one who's going to be that deeply interested. Subspecialty training, you need to show commitment. Commitment comes through your attachments, what you've done. A year working with an oncology surgeon. You mentioned Lee Jays. Lee Jays was my trainee. I was his training program director. So you need to show commitment. And absolutely agree. This 2-week fellowships and then writing, I've been to Korea for 2 weeks. Come on, you've had a holiday there. Don't kid yourself. Don't kid yourself for going for 2 weeks to Korea or Japan. You've just had a holiday and somebody else has paid for it. Let's be honest. Don't kid yourself. You cannot learn anything in 2 weeks. You cannot.
Yeah.
You just cannot. You have to show commitment of going there and spending a year, a minimum of 6 months if you've got enough experience. Sir just described, he gave up his private practice and he used to go down to Pune. I mean, that's commitment. That is commitment. I've done the same thing. I learned knee surgery from Bristol. And for 4.5 years, I commuted between Leeds and Bristol. Not every day. It's not possible to do it every day. But every week, leaving my family in Leeds to Bristol to do it. As far as publications are concerned, when you start seeing commitment, you will start looking laterally. In order to get publications, you need to look laterally and beyond the box. There was a presentation before. When you start looking beyond the box, publications will follow.
So I think, sir, for structured fellowship programs where your CVs are going to be analyzed by someone, publications do make a difference.
Of course. Now, if I've got a CV which has got, if I'm talking about the UK thing, they've got an MRCS. Yeah, everybody's got an MRCS because that's the basic. Then I see that somebody's gone and done an MD or an MSc or an MPhil, and they've spent some more time in research. They've actually gone and done another fellowship somewhere. They've got a teaching degree. They've learned how to teach. That just gives you points. These are these imaginary points that a person who's analyzing the portfolio looks at it. And then you come down slowly. Your thesis. Now let's be honest here. A lot of thesis is Xerox copies of previous thesis. I've been there. Okay? And exactly the same situation, what happens is, because you bring your thesis on the last day, and because a tutor or the mentor hasn't had time to read it, they sign it. Whose fault is that? it is the teacher's fault. And I say that as a teacher myself. Now, I would get penalized in the UK if I left it till the last minute to sign it.
Do you also feel that there is a matter of luck? So as sir said, he had the opportunity to assist somebody who offered him a fellowship. A similar thing happened with me. I've done the niche fellowship at Exeter, which is quite competitive, the clinical one. And it was because somebody dropped out at the last moment. My boss happened to know somebody there. He put in a good word, and I happened to be at the right place at the right time.
Yes, of course. But you create your luck.
Yes.
Correct.
Your boss said the right word for you because you showed commitment at some point that impressed him. If you were, I can't, I dekha jayega, kal hoega, he wouldn't have done it. You create your own luck.
So we'll move on to the next question. So when you are looking at a fellowship, like all of you have done fellowship from esteemed institutes the world over, what are you exactly looking at? Is it just the surgical caseload, or what is the overall academic or the teaching environment? Does that also count? We'll start off with Dr. Manit.
So, I mean, like in the previous session, selecting a fellowship would be like selecting a journal. You would start at the top and then probably go down. I was lucky to get the top option, which is Mount Sinai Hospital in Toronto, which is one of the best oncology fellowships across the globe. But that's how it goes. I mean, you start at the top and then you have a second choice, you have a third choice, and then you keep applying, keep working, show commitment, keep doing work, and you will get the opportunity eventually.
Right. So there is a very small minority of people in India who have done focused research fellowships, and Dr. Prashant is one of them. So Dr. Prashant, what was your thought process while going into a research fellowship program, and were you exposed at all to any clinical work, or were you, like entirely in the lab?
See, once you're decided you're going to do this fellowship, you're going to spend time away from your family and away from your practice, probably funded, not funded. So you got to make that choice, what you're looking for. Because a lot of people call me, hey Prashant, Korea mein 6 mahine ka fellowship, 6 weeks ka fellowship de de. We can paste it, we can show it to the corporate world that we have done it, and we'll get the job, right? This is the clinical scenario, this is the actual scenario. But you have to understand that I will not rule out 2 weeks fellowship. I think they still have a place. I'll tell you why. If you're in early part of your career, you're decided, I want to become a shoulder surgeon. Okay, fine. Go to a person who is a shoulder specialist and with a lot of cases. That is when your surgical load matters. So in your early part of your career, when you have decided the specialty, go to the surgical load in that specialty. Don't waste your time here and there. Yeah. And do this fellowship as long term. Minimum 1 year is what I give. All right. Now, once you come back and you start doing your cases, now you want to go to another level like revision shoulder arthroplasty or something. Yeah. Then you go to a place called as or something like Endoclinic in Germany, which is a specialized center only for revision arthroplasty. You don't have to spend your 1 year there because you already have your bases covered. Depending on, because you cannot spend like 6 months when you are, sir was able to do it and really admire that. But it's very difficult for people to do that.
So I think once you achieve a certain level of surgical competency, the nitty-gritties of that particular branch, you can perhaps inculcate just by doing a short-term fellowship. That is where perhaps the 2 week or 3 week
it still has
play a role.
But then you're not comparing apples and apples.
Absolutely. No. You can't call that a structured fellowship.
You got to have your
clinical
perspective.
Yes.
It's like a top-up.
Yes.
Correct.
Yes.
Perfect. So now going back to the research fellowship, what do you expect? In my research fellowship, I used to go to OR every time, but because I did not do my USMLE, I could not scrub in the cases. It is not like in the US, that is the case with every research fellowship. You have to understand how it works. In US, in every university, they have, orthopedics department has funds which are donated for research fellowship, right? They are lying there in some of the universities, they are not utilized. Yeah. Now you go apply for that, you have to keep applying. It's getting a fellowship,
job, essentially.
Getting a fellowship
create
is
a job proposal.
Yes, getting a fellowship is hit everything at the wall and see what sticks, right?
But that's interesting to know. You were allowed in the OR because in Canada it is not so. Like if you're a research fellow, you're purely limited to the lab. You don't even see the hospital side of things.
So I was at Johns Hopkins and that's why it was so strict. But I know people for sure who were doing a research fellowship but would scrub in a case.
Okay.
So that is also a possibility. It is not given away. So you do have clinical exposure. Yeah. You depend on what you call clinical exposure. Every time you have to cut and see, is that the clinical exposure? It's very important. Yeah. But that's not the only thing you learn. Everything I know about shoulder arthroplasty, I've learned from going there. And so that's what I would say, that don't think of only cutting and doing it. Yeah. Research is a skill set which will help you your entire life. It is a skill set like driving a car. You spend enough number of hours and you are able to, drive while drinking Pepsi, whatever it is, right? Research is a skill set, so you got to, if you want to be like an academic practice, you got to spend that much time doing a specialized research fellowship. It could be worth it. It depends on your interest.
So about fellowships in India versus fellowship abroad, madam, you've done fellowships in both places.
Yeah.
So what has your experience been in terms of, say, hands-on clinical work, level of, or the amount of clinical work you are exposed to, the amount of responsibility you are given? So what has your experience been?
So when it comes to caseload, yes, we are far ahead of all other countries. While I was used to a huge OPD at Wadia, and I spent like 1.5 years before going abroad. So US, we used to have just 5 or 6 patients in the OPD, hardly anything. Here, I mean, I had seen the whole, such a big, like the entire array of it.
Yeah.
And when I went to US and Canada, I went for a very subspeciality in pediatrics. So I just went for brachial plexus, that to just learn the glenoid osteotomy. So I had applied for this like 2 years before. And both my mentors, they prepared the list and OPD for 8 months to decide that during that 2 months,
You could
they
make
will
most
be,
out of
yeah,
those 2
so
months
they will be
yourself,
able
yeah.
to show me 30 patients, have me in 2 clinics and show me 6 cases in the OT because I am coming for that
Only
particular
that,
program.
yeah.
And that was through Pediatric Ortho Society of North America, which is again a very competitive thing to apply because all countries, people apply for that.
Yes.
And this was like a subspeciality. Like even in pediatric ortho, it is like general ortho, but
Yes.
treating small humans.
Yeah.
So now we have subspecialized as pediatric ortho hand
Shoulder,
specialist, pediatric ortho hip, and I particularly do pediatric ortho neuromuscular. So I do CP and obstetric palsy because I
Fantastic.
spend time that way. So I think that's how we can focus more, and work-wise we are much more better. We have to just get the niche part, learn from outside something additional, and
Yes.
come back and serve back, I think so.
So,
Let's
let's
start with Dr. Gupte, sir.
Yeah.
Did you have to give any exams or local licensing work did you have to do in Korea? Or any registration to operate there?
No, the exams. The local registration, yes, that was done by hospital. But just, I'll come back to previous question
Yes, sorry,
also.
yeah.
Okay. See, you are going on going abroad on a fellowship basically to learn. Your main aim is to learn,
Yes.
not amount of cutting, how much cutting you are going to get. And learning can be done by observation also. Okay. The place where I went, it was a dedicated spine surgery, minimal invasive spine surgery center. They used to operate at least minimum 50 spines every day. And I was with my mentor, we used to do almost 7-8 spines. There was no free hand. I used to be with him as a first assistant. But best learning what I had was day before. In evening we used to sit together, discuss next day's OT list, and my boss used to plan each and every case. He was such a particular person that doing complex spine tumors or anything, he used to plan how we will be putting his hand where and what will be his finger movements. To that extent, he used to plan.
Yes.
We used to analyze MRI and CTs to such an extent that before taking an incision, we will know that at which point we'll be encountering nutrient vessel on a lamina. So that amount of planning
Meticulous
and that
planning.
amount of learning was a real learning.
Yeah.
So once you plan that, doing surgery is cakewalk.
coming
So-
back to, sorry, you were saying something.
So the licensing part, because a lot of times what the trainees in India, the obstacle which is faced is that unless you have a particular exam or if you have, unless you have say cleared your MLE, you're not allowed to operate or scrub up in foreign countries. So did you face any such obstacles in Korea or no? There, you
No,
got a limited
no,
registration
no,
there?
no.
Okay.
So now there are recent guidelines. My last year, one of my ex-fellow went to the same institute where I had done the fellowship. So he had to get a local license from here, MMC or MCI, which then gets approved there. And he works as a clinical fellow because then he is allowed to do his own case individually or manage one OT like a senior fellow.
Correct.
So
But there were no
currently
exams
we
which
need,
had to
no,
be
we
taken
don't need
because-
exam,
so-
but we need a local, like a good standing certificate, and there is another one more certificate which they send a format.
Because I had to clear the MRCS to get a GMC
Yeah,
registration
so-
in UK.
Exactly.
And
That-
that is extremely important for colleagues to know, to do the basic research as to what is required in order to do a fellowship. Because if you want to do an observership, it is relatively easy. But an observership works if you've already got experience. Where if you've got experience, then by observing other people, you can develop the skills to a certain extent. But if you are at the beginning of at the bottom of the ladder, then an observership doesn't always work because scrubbing in works.
Yes.
You may not operate, you may not hold the knife, but actually holding the retractor gives you a much better exposure than standing outside the tent and watching. Now, in the UK, the biggest problem, as you've already highlighted, is that the GMC does not allow you to touch a patient in any way, shape, or form if you do not have registration. Now, that is the biggest drawback that we are facing. But I can tell you that the UK will be opening up again. But there is going to be a massive, and why will it open up? Because we've got a serious shortage of doctors. Serious shortage of doctors because the EU guys who had blocked the Indian doctors.
They can't speak English.
Well, they can speak English. Then, to be fair to them, they do make an effort to make sure that they can communicate. But they are not going to come in anymore because they're going to go into the same pool as you and I, pre-EU. Therefore, it's a chance for you, budding young surgeons, to shape up your CV, start looking for opportunities, get your MRCS because the MRCS exam is local. You don't have to travel to get it. But you need to get going. You have to drive yourself. Nobody is going to drive you. Nobody's going to push your car. You've got to step on the accelerator and get going. And that's
And I
important.
feel one more reason why the European trainees may not come to UK. I had a Hungarian trainee with me. So his training was recognized in the UK before the EU referendum. But now they have an additional hurdle of clearing the English language test. And a lot of them have a real problem because it is not something which they are used to. So I think that is going to be a hurdle for them. So
Absolutely.
probably our trainees will have a better chance of getting.
And
So
it is-
something
it
to
is
really make a note of.
Really
for
make
all,
a note that the
yeah.
UK will open up again.
And maybe in another 5 years it's going to get saturated again. So this
Yes,
is like
it's a
golden
cycle.
period. Yes.
It's a cycle. At the moment, we are short by about 20-30% doctors across all specialties.
Yeah.
So there is a huge opportunity.
So as you said, right place, right time. So I think
Right
sir
place,
is
right
the
time.
right place, the right time to guide youngsters. Yeah.
So, just wanted to interject at this point. Will we lose a lot of our Indian talent again and have a brain drain? Is that kind of scenario what you would be predicting?
Great question. Guys, India is a land of opportunities. And before you actually step aside, as this is a man, you'll probably say he sat there for 30 years. Now it's very convenient for him to say India is a land of opportunities. But when I left India, when I left Mumbai, there were only 4 hospitals in Mumbai. There was Bombay Hospital, Jaslok, Hinduja, and Nanavati. Lilavati was under construction. There was no other hospital. There was no opportunity. There was a lot of nepotism. I didn't have a medical background. I found it extremely difficult to break into the corporate sector. Extremely difficult. My wife is a pathologist, and she was offered a job as a laboratory technician in Lilavati for 10,000 rupees. She didn't take it. I wasn't surprised that she didn't take it. She said, I'm a double MD and I'm getting 10,000 rupees in 2003. We tried to come back till 2005. And finally we said, no, I think we'll stay there now.
Yeah.
So please don't forget your roots. Please don't think that the grass is greener there.
Yeah.
The grass is the same color. The headaches are the same. But I think I will be right in
Different
putting
set of
this.
headaches, perhaps.
Different set of headaches,
Yeah.
but the training is better there. You will
Yes.
come back a better trained surgeon and hopefully more disciplined. The one thing I'd love to see in Indian medicine and Indian orthopedics is audit of our results. We are very scared of declaring our complaints, our complications. Look, there are only way you cannot have two complications. There are only two ways. One is you don't operate, and therefore you don't have any complications, or you just lie. If you are a surgeon, you will have complications. You can have it once. If you reflect on it, you will not do that complication again. Most people say, मेरे हाथ में infection नहीं होता है, सबके हाथ में infection होता है. छुरी पकड़ोगे तो infection होगा.
Yes.
Yeah. And we lose patients to follow up. Indian patients have a weird mentality. Sorry, apologies, I'm very much an Indian. एक बार खराब कर दिया, दूसरे बार उसके पास जाने का नहीं है. And as clinicians, we have this deep inability to actually tell that the guy whom you've gone for the first opinion is correct. Please follow up with him.
Yeah.
We always have to give a diametrically opposite opinion, and the patient gets confused. All that happens, patient then goes to a third person, who then gives a third opinion, because there are so many opinions in orthopedics. There are so many operations in orthopedics. But they are all brothers and sisters of the same principle,
Yes.
but we define it differently.
Right.
We have to unite ourselves and accept that if the primary physician, primary surgeon has said, needs a total knee replacement, don't start saying, injection se theek ho jayega.
So, quick round of questions about the expenses which are incurred during the fellowship, and if you had any monetary remuneration during your fellowship. Manit, also seen in Canada, did you have to spend a lot of money getting licensing, renting a place there, travel, all included?
Yeah, so there was an initial expense which I was paying from here to get my registration licensing started, but I was paid a basic stipend, and in the end, I think it broke even.
You broke even, okay.
Dr. Prashant,
Very clear.
question for you. There is a query in the minds of like many of the residents that they want a paid fellowship, but they don't want to go through the process of the licensing exam. So what are the options for like a funded fellowship without going through the licensing exam?
Okay, quick answers. Number one, all my fellowships were paid. I will give you numbers for sure so that you guys can.
Yes, yes, that
So
would
this was 3 to 4 years back or something. I was in South Korea. I was paid 60,000 Indian rupees to 1 lakh Indian rupees, which is good enough per month, which is good enough to survive there. But no,
You break even
perhaps
and maybe have some fun.
perhaps yeah,
Yeah.
some fun, yes. In US, it was about 2.5 lakhs or 3 lakhs per month,
Yeah.
which is you save a little bit, but 2/3 is gone.
Yeah.
Okay, so that's putting things in perspective.
Yeah.
Now, going back to funded fellowships without doing a license. So I wrote this article in Bombay Orthopaedic Society magazine last year, I believe. There are nerd guidelines in order to get in order to get any fellowship. N is a networking. I talked about that earlier. I'm not going to emphasize on it. Second is exams. I really believe that if someone wants to excel in their career, if I had to go back and do something, I would really give a licensing exam either in the UK or the US and get the clinical experience along with the research experience. Okay, so I would recommend that. But if you're not doing that, then networking becomes your key factor. NER. R is your research, and D is your diligence. Diligence is doing a job perfectly well or at your best, and also making sure to see that it is done, not just putting efforts.
Madam, about Korea, was it paid?
Yeah. So I was in
And
a
could you break
structured.
even?
Yeah, yeah. So they
Could you
took
save a
care
bit?
of the housing.
Yeah.
I saved and I used it further when I went to US and Canada. So, and
So-
it was the same amount what he got 4 years ago. I got like around 14 years back. So
There's
that's
no inflation
quite
in Korea,
huge.
perhaps. So in UK, the fellowships are paid. I was a registrar for 3 years and I did 3 fellowships, and the payment is similar to what Prashant has said. Yeah.
So we'll quickly move.
People to sit down. There are lots of chairs in front here.
So there are a few more questions. Should we carry on? Or?
Yeah, we'll so the next session is going to be a continuation of this, and I think the target audience is going to be the same. So if they don't mind, we'll try to stretch on this session and chaff out as much of doubts in their minds as possible. So we have prepared some questions, and of course, if anybody from the audience wants to ask something, they're free to put up their hand. So what is a working week like? So for example, in UK, we used to have 2 to 3 operating days, 2 clinics, 1 research day, 5 days a week. That used to be a routine week. In Canada, Manit, quickly.
The unit which I was in had 3 consultants, and they each had their operating and clinic days, and we were 3 fellows, so we just distributed ourselves and rotated through the units. So it was 2 days clinics, 2 days ORs, and 1 day was basically research and discussions.
Okay.
5 days working week, both in Korea and US, but there are always deadlines, and it always depends on you how much you want to put in. I would work 6.5 weeks, I would say, just to make the most of it, because there's the golden
So you put an
opportunity.
extra effort to...
Exactly, because you're going to travel later in life and you have money, but you
Yes.
got to know why you're going there.
Madam, in Korea,
So they work like us, Monday to Saturday,
Right.
but US, of course, Monday to Thursday, and
Okay.
Friday is research day. Canada also, it was same.
Yeah.
My time it was 5 days in the sense Monday to Friday, full day OT. We used to start 9 o'clock in the morning. Before that, 8 to 9 will be small conference where we'll discuss that day's operation list. Saturday will be grand conference in the sense we'll
Discuss
discuss
everything from
difficult
the last
cases
week.
and all. Then Saturday, Sunday will be free.
Okay.
and what was the surgical load like in terms of you operating as a first surgeon? Manit? So in UK, in a 6-month fellowship, you do around 50 to 75 joints, maybe around 15 to 20 ACLs as a knee fellow. How about Canada?
So in Canada, since we were licensed, we had a dedicated fellows clinic, and most of those patients were screened by the consultants, and patients that converted to OTs from fellows clinic were fellows cases.
Yeah.
So we ended up doing close to about 100 cases in the year.
Okay. Korea?
Korea was about 1,000 knees, I would say, per year, and a crazy amount.
Independently?
And, not,
In terms of
always
independent operating?
either assisted or very few chances of supervised.
Okay.
In US, about 400 total shoulder replacements, all observerships, but people who have
Was a
fellows,
research
they are...
fellowship, yeah. So the clinical fellows did operate some of them. So it was a hands-on.
Yeah, so clinical fellows are
Yes.
allowed to operate.
In Korea as well.
And like I said, they were happy that I had already worked 2 years in Vadia.
Yes.
So immediately in a month's time, I was allowed to do all the surgeries.
Fantastic. So it does matter at what level you're doing a fellowship as
and
well.
the ones before me, they had never got this much opportunity.
Yes.
That's what the boss
So
had
if you're
also
doing a knee
mentioned.
fellowship and you already don't know how to do a knee
Yeah,
replacement,
then
then
they
it's not
don't
going to be
allow.
worth it. They're not going to sit and teach you how to do a primary knee. Yeah.
My time it used to be like I told you that we used to, that per day at least 55 to 60 spines.
Yeah.
My unit we used to operate about 7 to 8 spine
Fantastic.
on, never as a independent surgeon, but first assistant almost all.
Okay.
And my boss used to do decompression. I'll be putting pedicle screws.
Okay, fantastic. So I think we are running slightly short of time, so I'm going to stop my line of questioning here. Does anyone from the audience want to ask anything about any aspect of getting a fellowship in any of the countries where yes, please.
So basically the question was like everyone right now, the surgeons who are there, they've done a fair share amount of trauma before they've opted for a fellowship. And right now people are just post MS 1 year, 2 years, they're selecting fellowships in knee, scopy, spine, whatever. So how does that differentiate? When would you select to be a good time? Of course you sir would know much better because you've done 15 years of private practice before selecting a fellowship.
Yeah. No, I'll tell you my mentality in the sense I'm practicing purely as a minimal invasive spine surgeon, and last 10 years here I'm getting fellows with me, and my selection criteria is whoever comes to me wants to do a fellowship with me, he must have done at least 1 year spine fellowship, dedicated spine fellowship, then only he is selected. Because I don't want to teach him from beginning, like how to select entry point for a pedicle screw when you want to teach him percutaneous pedicle screws.
Yes. Unfortunately, that's a conundrum that you need experience for getting a job, and the job gives you experience.
They should apply for a SR-ship. Suppose you are
Yes.
interested, you should take up a SR-ship where spine work is there. Because
Yes.
see, everyone wants
Correct.
somebody who has a basic exposure. Nobody wants a fresh person in that field.
Yes.
So go for a hospital which has that pertinent work going on more, and of course people will select you because no one wants a fresh fellow,
Yes.
like
And
Sir said.
Eventually, fellowship is just a tag. Eventually, it's about how
Yeah.
much you know before you apply for a particular job, which is going to train you further.
And publish 2 papers in your SRship.
No, basically my question was that after MS, do you do a certain amount of trauma for a few years and then join the fellowship in a specific field?
For any subspecialty fellowship or subspecialty surgical orthopedic training, your knowledge and experience of how to handle trauma becomes extremely important.
Exactly, sir.
So your handling of soft tissues wherever, whichever part of the body is very important, and no better place to learn it from handling damaged soft tissues around the fracture. So
yes.
the trauma bit is absolutely important, and that's why in the UK, our degree is in the generality of trauma and orthopedics rather than in the subspeciality of any particular
Yes.
thing. That also allows you to think laterally as to what you want to actually do, what interests you, what gives you the buzz, what actually makes you wake up from bed and go to work and say, right, I want to do knee surgery because I'm intrigued by how the ACL works. And whether that develops in you doing some research about the ACL or learning how to reconstruct the ACL, and that's the time to think. Because 3 years in doing your MS is not adequate exposure to concentrate on what you are going to specialize in. And I again repeat, market forces often direct you because you look at it and say, the arthroplasty surgeon is making much more money than the pediatric orthopod, and therefore I want to be a knee and hip and knee arthroplasty surgeon. That's what is happening. But that's not what is tickling you. If finance tickles you, then you should be in the stock exchange. But if finance doesn't tickle you, if orthopedics tickles you, then you should look at what your career interest is.
Thank you, sir. Any further questions?
One just additional comment
Yes,
that I want
closing
to make,
remarks, madam, yes.
Because I find this a very dangerous trend which is coming now when we get applications to Vardia also. Fresh MS and they want to have the fellowship label in pediatric orthopedics. So when you're looking at a fellowship, please focus on what you want to learn and what you are able to do rather than expecting a spoon feeding. Now, be this in India, be this abroad. Because remember that it's ultimately the patient care which is going to suffer.
Yes.
So I think a lot of us, yeah, it's good to have a training abroad because you see structured training over there.
Yes.
But lot of our own centers, like she said, 2 years in Vardia, when she had done everything with us,
Still
they
there
were
was
happy
much
to
more
give
to
her
do.
that.
Yes. Yeah.
And we still, at the end of 24 years in pediatric orthopedics,
always more
also
to learn.
feel that there's so much more to learn.
I'm glad you brought that
So-
point out, madam, because the next session is exactly that, what the mentors want and what they look for while offering or selecting fellows. So with that, I think we'll close this session. And for our next session,
A big thank you to all the panelists for joining and dedicating your time and experience. We'll do a quick group photo before we move on to the next part of the same session.